Okay, maybe we'll get started this evening. My clock here in Calgary says about 5:30. So welcome to the Thursday evening PCN pain rounds. Tonight's topic is understanding gender diversity and chronic pain, inequities, insights, and inclusive care with Dr. Effie Mogianis. She's a PhD and registered psychologist. We will provide a short bio after these intro slides. I have placed a longer one in the chat if you just wish to know a little bit more about Effie and her accomplishments. So next slide, please. I'm just toggling between kind of two different screens here. So excuse the just the quick pause here. We'll start off with a land acknowledgement. So we want to acknowledge and honor the fact that those of us that are participating in the event across the province share the traditional and current lands of many First Nations. This includes Métis and Inuit people whose resilience and presence with us remind us of our treaty obligations and relationships. The province of Alberta includes territories and treaties of 4, 6, 7, 8, and 10, which include a diverse array of culturally distinct Indigenous people whose history, languages, cultures, rituals, and traditions continue to enhance our communities and remind us of our ongoing relationships with one another, the land, and our own processes of reconciliation. Excellent. Next slide, please. So this program receives in-kind support from the Alberta College of Family Physicians in the form of webinar infrastructure. Our planning committee would love to introduce Jan Jelinek. He's a behavioral health consultant or professional, I should say, with the Mosaic PCN. Dr. Janet Hurley, who may be online here, is also a physician with the Mosaic PCN. If anyone is here from Calgary West Central, we have a vacancy, and we'd love to fill that if anyone within that organization is interested. Bow Valley PCN, also vacant. Paul Fulbrook, he is a team manager with the South Calgary PCN in their pain program. Regan Paddington, clinical operations director over at Highland PCN. Dr. Lori Montgomery is our PCA Calgary pain program representative. We have a vacancy, Calgary Rural PCN, and it's a pleasure to meet all of you. My name is Nicole Dowling. I am a social worker and a mental health consultant with Calgary Foothills Primary Care Network. The background on these rounds is it's open to anyone, and it's really designed for primary care teams. These events reoccur 6 times per year, typically rotating weekdays anywhere from about 5:30 to 6:45 using the platform of Zoom. Historically, there have been some lunch and learns, but this seems to be the time that works best for our audience. And the focus is really on chronic pain and issues common to people working with pain. Next slide, please. There is a question and answer function. Of course, please ask questions related to the talk and use the chat box if you have any technical or logistic questions. We have designated or carved out time at the end of Effie's presentation to ask questions. So we'll be sure to be very mindful of time today, just as per some of our feedback from our previous session in July. Your feedback matters, and what it does is it drives future sessions. It tells us what we can do a better job of, what you enjoy. And so you will see a link in the chat box towards the end of the session, and also an evaluation form will show up. Please complete this if you are claiming some CME credits. You will need to do the evaluation in order to get the certificate. Next slide, please. Upcoming rounds, we've got improving pain care for Indigenous peoples, parental responses to pain in children, digital solutions to scale up pain psychology, neurodiversity and pain, part 2, and the role of primary care in managing pelvic pain. Thank you. We have a poll, and we'd love to see who's in our audience today. And so what will flash up on the screen is just a, yes, your discipline, if you wouldn't mind. Okay, I see the kind of the little blue lines moving still. So what I'll do is I'll just start to kind of share who's in our screen, or sorry, our audience, our screen. Family physicians making up a majority of our audience. That seems to be, a trend that we see often. The next section is other physicians, nurses, making up 27%. NPs, unfortunately, no representation in the crowd today. Pharmacists, making up 7%, and physiotherapists, I should say, making up 3%. Occupational therapy as well, psychologist and or BHC, and no student or other. Oh, maybe there's some other just peeked up on my screen. Thank you very much, guys. Oh, and speech pathology. Thank you. And social work. Wonderful. I'm also a social worker as well, so it's nice to see uh, some representation here. Wonderful. Next slide, please. Okay, this one pertains to PCN location. Okay, so I'll start with the results here. Unfortunately, we don't have anyone from Bow Valley, Calgary Foothills. It's making about 23% of the audience. We have Mosaic represented and South Calgary both at 4%. Um, what else do I see here? Oh, other. So these are other Alberta PCNs at 8%. And Alberta not assigned with a PCN is actually 62, which is great. Thank you very much, guys, for taking part in our poll. Next slide, please. Oh, for whatever reason that popped up. Okay, so today's learning objectives, understand the overlap between chronic pain and gender diversity, develop an inclusive and affirming approach to assessment and treatment of trans slash gender diverse patients, learning about the underlying health inequities and discrimination faced by trans and the GD community, and gain resources to support gender diverse patients and their families as well. All right, and I think we've got one more slide, so I'd love to introduce Effie to you. She comes to us with a background in pediatric and health psychology. She also has done extensive work in interdisciplinary medical settings. Her work focuses on minimizing health disparities through advocacy and adapting evidence-based practice to underdeserved communities. She holds a bachelor's degree from Smith College, a PhD in clinical psychology from Georgia State University, and completed a postdoctoral fellowship at Harvard Medical School, specializing in pediatric and health psychology. Effie works in the Calgary Chronic Pain Center as part of the Primary Care Alberta. Prior to moving to Alberta in 2023, she worked with adolescents and young adults affected by chronic pain and chronic illness at Kennedy Krieger's Institute Specialized Transition Program, an interdisciplinary day rehabilitation program in Baltimore as part of the Johns Hopkins University broader network. So without further ado, I would love to hand the mic over to Effie. I'm looking forward to her presentation this evening.
Wonderful. Thank you so much. Let me
Yeah.
go ahead and get myself started on my share screen here. All right, I think we're all set. Thank you so much for having me. It's a pleasure and an appreciate you all being here this evening. I would love to see faces. So I know it's after hours, so some of you might be eating dinner and multitasking with families around. But if you're able to pop on screen, that's great because I get to see your face and see how the information is landing. And I look forward to being here and presenting this information with you tonight. In terms of financial disclosures, I have none to disclose this evening, and that our Zoom platform was provided by the Alberta College of Family Physicians. I did want to just briefly acknowledge we did a land acknowledgement already, and I can just, I'll move forward for the sake of time. We already were outlined here in terms of objectives. I think that I will be able to hit all of these this evening. I will leave you with some resources at the end, and hopefully those resources can continue this work in whatever practice that you're in the primary care networks. One of the things I wanted to start with tonight is a bit about myself. And the reason for this is because a statement of positionality, as we like to call it, is really important. It really gives us an idea of how we see the world. These identities are lenses by which we see our patients, treat our patients, engage with others all around us. And so these lenses that we see the world, the backbone at essentially is some of our identities. And so I wanted to share a few with you that you'll probably hear to some degree in my work tonight. So I am genderqueer. I use both they, them, and she, her pronouns. I'm partnered to a cis female who is an academic researcher, and we parent a LGBTQ self-identified tween. I immigrated to Canada couple years ago. I grew up in America, but I'm born to Greek immigrant parents. And I have a PhD, and that is the lens by which I see the world and have gone forth in this work. So one of the things I wanted to do is to kind of start off with foundational knowledge, and I will acknowledge that some of you might be way past this in your knowledge, and some of you, this might be a good refresher, and some of you, these might be new words, and that's fine too. But to be able to launch forward, doing a bit on definitions is probably the best way to start. So sex versus gender, this is a really important one. Sex really just refers to sex assigned at birth is actually a more proper term, because that then includes this idea of potentially intersex as well. Person's sex is really a composition of the genetic, physical, including genitalia and secondary sex characteristics. And those pieces are really, from here on forward, I'll probably just be referring to them as sex assigned at birth. Biological sex tends to be a briefer way that people refer to it, but a more proper way to refer to it is sex assigned at birth. Gender is very much a social construct. It's cultural, social, and psychological in nature, and it refers to the psychological and behavioral and cultural characteristics associated with maleness, femaleness, intersex, neither, both, another gender, and much, much more. And the bulk of today's talk will be focusing on this aspect of gender. A few other definitions for us tonight. Gender role really refers to behaviors, attitudes, and personality traits in a given society, often in a given period of time, that are designated by a particular gender, whether that's in the binary, which is male, female, or another gender. Gender expression is the way that we show our gender to the outside world. This could be done with hairstyle or clothing, our mannerisms, our behaviors. And a word I've already used that I didn't define is the gender binary system. You'll hear me talk about this quite a bit tonight. It's this dichotomous categorization of male and female that we tend to use. And there's lots of indicators, both scientific and social, that tell us that actually the binary is a constructed system that we've used to sort of sometimes simplify our lives, but in reality doesn't really reflect what is life around us. Cisgender. Cisgender is a person whose gender identity is consistent with a traditional sense of their sex assigned at birth. An example of this would be somebody who identifies as female and was assigned female at birth would be called a cisgender female. Transgender. Now, this is an umbrella term, and so we'll go on, talk a little bit about this a bit more, but generally describes a person whose identity and sex assigned at birth do not correspond based on traditional expectations. Um, I use these definitions and I say to hold them as a piece of information, but to apply them more in a flexible way in your work because they might mean something different to each person in front of you. And I'll refer back to transgender and gender diverse throughout this presentation as you get a little bit more of a nuanced understanding of what it might mean. Non-binary, sometimes abbreviated as NB, the letters N and B or ENBY, describes somebody who falls outside of the traditional gender binary system or, male, female, maybe describes themselves as without gender or a multitude of genders. And finally, gender affirmation. Gender affirmation is the process of making social, legal, and/or medical changes to recognize, accept, or express one's gender identity. And these social changes can include pronouns, names, hair, clothing. Legal changes include changing one's name, their sex designation, and gender markers on any sort of like legal document. Medical changes can include receiving any sort of gender affirming hormones and or surgeries. This process has historically often been referred to transition, although gender affirmation is really what should be used. I'm going to show you a little bit more on the breadth and depth of identities here by using a few of my some of my favorite images. This is the gender unicorn. I often use the gender unicorn as a teaching tool. I use it as a therapy tool as well. The gender unicorn is fantastic because it shows the complexity of all of these different identities, how they can be related at all or minimally or a lot. And what I really, really like about it is that it kind of breaks down and shows how there basically is an infinite number of identities. So when I worked with young adults and adolescents, I'd often who are exploring identity, I would take out the gender unicorn and have them draw a little line on some of these arrows to talk about, where do they see their gender identity, which, has a little rainbow that lives in their head, or their gender expression, which is the way they show gender to the outside world. Sex assigned at birth is the cute little multicolored double helix there. Physical attraction versus emotional attraction and how they overlap a little bit, but they are different entities. The other piece that I will say, I'm not today talking about sexual minorities or sexual orientation. And I think often sexual orientation and gender identity are often put in the same bucket and sometimes even conflated. And while they are actually distinct and separate entities, they can be connected in many, many ways. And so some of these tools help us disentangle some of these pieces when somebody is in front of me and we're working through pieces of identity. This is another great image that I've used from a lovely book, and this is all the different ways that transgender can be. This is not an exhaustive list, but there's this great rendering of this umbrella, and you'll hear us refer to it as an umbrella term. And underneath, there's a number of different trans identities or gender diverse identities that vary culturally. And this idea that gender actually is a spectrum. It's not this dichotomous system that we tend to kind of try to neatly put things into, but it's beautiful and it's broad and it's fluid. And so some of these identities under here might be ones that you're familiar with, and some of them might not be ones that you're familiar with. But they have been around since actually the beginning of time. And I think sometimes when I give this presentation, I occasionally have a hand up in the audience that says, this seems like a new phenomenon, like, all of a sudden, maybe brought on by media or something like that. Help me understand. And one of the things that I started including as a teaching tool is this fantastic map that is actually, you can actually play with it online. It's on the PBS website, the National Broadcasting in the United States, but it's created by someone. It's freely available. And you can click on each one and it tells you about these gender diverse communities and cultures all across the globe that have been there since the beginning of time. What we do know is like the sociopolitical zeitgeist has been changing and the media has helped. And it's not that we're just seeing more quote unquote cases of gender diversity. But in fact, it has been there and Western culture, has pushed forward this sort of ideology of two cultures or the binary. And in fact, it's kind of erased in the ways that Western culture sadly has a history of having done, indigenous cultures that often predated it that have gender diversity at its core. And gender diversity can look like a third gender or a gender that includes both the male and the female. And it's really quite interesting when you look around the globe and see all the different representations of gender diversity that exist within cultures since the beginning of time. And they're often revered folks of these communities. Mahu in Hawaii is a native position that is a third gender, the Fa'afafine in Samoa. They're just often very revered folks of those cultures. And so this seeing the breadth and depth of it is really, I think, really lets people know that, hey, like this is not something that we just recently are seeing. Um, I think that sometimes the medical world side of things has treated it as such, as that it is something that we're first seeing. And we see that represented by the Diagnostic and Statistic Manual and gender dysphoria. So the concept of gender identity, gender dysphoria appeared for the first time in the 1980 edition of the DSM. And it was really quite problematic. And the latest CSM, DSM-5, replaced disorder with dysphoria in the diagnostic label. It's more appropriate and consistent with more familiar clinical sexology terminology, and it removes the connotation, generally speaking, that the patient is quote unquote disordered. Um, and, some of the other important things to note on here for a person to be diagnosed with gender dysphoria, there actually must be a marked difference between that person's individual expressed gender and the gender others would assign him or her, for at least 6 months. And that this actually causes clinically significant impairment and distress. So without that piece, it's not gender dysphoria. It must cause clinically significant distress associated with that condition. I'm stressing that because if it doesn't cause that, then, we're just kind of pathologizing gender variance. And many folks still believe even having it in the DSM is pathologizing gender variance. But on the flip side of the argument, one, it gives us sometimes we need, especially in the United States, well, less nowadays, but a diagnostic code to be able to like bill for treatments for gender affirming care, et cetera. So, what do we know about the condition of kind of health and how trans folks are doing in Canada? Well, the TransPulse Canada project was a huge project that was collected, I think the biggest one to date in terms of trans and non-binary people in Canada. It was about 2,800 participants from all over Canada, and the data was collected in 2019 over a 10-week period. It stemmed from an Ontario-based project where they had looked at a transgender and gender diverse population and decided they really needed to take a fuller breadth and depth of the transgender population. And when they started putting together this project, they actually identified 9 priority populations that needed to be focused on. And one of the populations that that I'm going to share with you and talk about tonight actually is the population of trans folks living with disabilities. To date, this is the first study, national study on health and well-being among trans and disabled folks, trans and non-binary folks here in Canada. So these are some snapshots of some great graphs from the Trans Pulse Canada. So some things to note. Almost 1 in 5 identified as disabled. Um, and that's about 19%. 59% did not identify as disabled, but identified as having a disability or chronic pain or chronic illness. And what I bolded here for you is chronic pain and chronic pain condition. So the most common diagnosis was actually a mental health condition, which is at 82%, but that was followed by chronic pain condition at 45%, and then chronic illness at 42%. Um, the highest proportions across most disability diagnoses in this group, actually, there was a lot of comorbidity. That's an important piece to highlight here. Um, and it's interesting. I think the study was actually really cleverly done to be able to break down because you're looking at both aspects of identity and some of these other pieces of diagnoses as well. Um, See some other important pieces. It tells you a little bit of breakdown among the different provinces and territories. That's helpful to know. And some of the other things that we learned from this study is 63% had and they described the past year prior to completing the survey had unmet healthcare needs, compared to 26% of the population without a disability or chronic pain or chronic illness. 38% often avoided the diagnosis of a health issue due to fear that it would somehow impact getting gender affirming care. And 28% reported discrimination and or exclusion from the trans or non-binary community based on their disability. So one of the things that's, a unique consideration to think about is the aspect of either double stigma or stigma of not fitting in one community or the next and how that impacts somebody's health. So the health inequities and discrimination. This could probably be its own presentation all into itself. Despite progress and accessibility and equitable care here in Canada, Lord knows right now it's far better than the United States. Um, there's still a lot that can be done. And what we learned from this data is that our transgender and gender diverse friends are really facing discrimination and inaccessibility when trying to utilize the healthcare system. They're talking a lot about, having these unmet needs, often refusal of care, and often having the burden of teaching their medical providers about proper transgender care. Many folks talked about when they're sick or they're injured, they'll just avoid healthcare in general for fear of discrimination. This number right here, over 4 times the national average, that actually comes from the National Trans Task Force in the United States. I don't know if it's roughly around the same in Canada, but at way higher rates of HIV compared to what we're seeing with the rest of the population. This is the most staggering number that hits me every single time. So in this particular study, 30% reported attempting suicide. And what I have there, 1.6% is generally around the base rate of what we see. 41% was from the biggest study to date in the United States. And that's huge. That's staggering, those numbers. And it says a lot about where folks are in terms of struggling with mental health and discrimination. We're seeing higher rates of trauma and significantly higher rates of depression and anxiety in this population. So how does this map on to chronic pain? So here is the biopsychosocial model. And to just do a brief primer and review on chronic pain here. For a long time in Western medicine, the prevailing model of understanding was this reductionist model, this idea, this biomedical model that when something was wrong in somebody, a presenting concern, patient comes in through the door, the first thing we were looking for is biological etiology, tissue damage. And as time went forward, we realized health was far more complex than that. And so George Engel in 1977 gave us the biopsychosocial model with the more complex understanding that we can't just look at the biology to help somebody with their health. It's far more nuanced than that, and the psychology and social context really matters in terms of treating our patients and really providing them with the best care possible. And so, what we do know about chronic pain is that it's different than acute pain. So, chronic pain, we often think about it lasting pain that's lasting for more than 3 months. Chronic pain can be related to some sort of biological etiology, but it doesn't have to. And in fact, when we look at the research, there actually is, a complex and murky relationship between tissue damage and pain levels. And so it's really important. This is the model that we use in the Calgary Chronic Pain Center to teach and to help patients better understand the various factors in their lives that they have more agency and control over. So our program, the Calgary Chronic Pain Center, is a program that's run by self-management. So we are giving our patients actual skills that they take in hand to be able to learn how to better self-manage their symptoms, to be living more of the life they want to be living. And so I show you this and highlight some of these aspects of chronic pain. And I want to bring out a couple of them. So trauma, depression, and anxiety, we know are risk factors. They run much higher in folks who they're comorbid, and the relationship is bidirectional in that we know, depression can make pain worse, and pain can cause somebody to feel depressed. Same deal with anxiety. And so we think about these pieces because we know that the research tells us that when somebody is depressed, if we're not treating their depression and just trying to throw, say, medical intervention at their pain, we're much less likely to be successful. It's really important to be able to actually concurrently treat some of these other pieces. So when you see chronic pain programs, such as the one that I work in, you often see psychologists as central fixture points in them to help address some of these other common comorbidities and risk factors that we see. So how does that map back on to the Canada Transpulse Canada study? Well, as we're looking at this, one of the things that we see is besides chronic pain, the other highest percentage we see folks identify is mental health problems. So here, I'm a little upset at this word mad, but psychiatric survivor, mad, or person with mental illness. That is at a really high percentage there. So we're seeing 70% of folks who identify as disabled hold that identity, and 50% who have that identity but don't identify as disabled. And we drop down to mental health condition. It doesn't differentiate here, but what we're seeing is this is the highest percentage. So for folks who are identifying as disabled, 82% of them are saying, yeah, I have a mental health condition. And for folks who are not identifying as disabled, 74% of them are saying, I have a mental health condition. And these things are important pieces that we have to pay attention to. Because we know that there are known risk factors. And so here's a list. This is from an epidemiological study from the British Journal of Pain of the known risk factors that are associated with chronic pain. And so why? Why is there, why did we put these two pieces together? Why are you sitting here listening about gender diversity and chronic pain? And the reason is there's an overrepresentation of trans and gender diverse folks in this world of chronic pain. To be honest, based on the scientific literature to date, we don't absolutely know for sure why. Studies are small, they're limited, and largely correlational or cross-sectional in nature, and really more research is needed. But what we do know, what does have a larger research body, is the risk factors for chronic pain. And this is something we have looked into and know more of. Is there still stuff that we're figuring out? 100%. Understanding some of the mechanisms, they're still really murky at best to us. But we do know that anxiety, depression, catastrophizing beliefs about pain have been shown to be associated with the presence of chronic pain, and tend to be a poor prognosis in people with various chronic pain conditions. And so when we look at these pieces, we see that they're also in higher, like the mental health pieces are in higher rates for folks who are gender diverse. And then we pair that with systemic discrimination. I mean, that in and of itself is probably explaining a lot of this overlap that we're seeing, this reason that we're seeing so many young trans folks coming in, gender diverse folks to clinics presenting with chronic pain. So I'm getting to the place of what can you do here? Because I think that's the crux of it. We want to, put some knowledge and tools and resources in your hands for you to be able to walk away this evening feeling like you can make a difference in this. One other thing I wanted to note is Health Canada a couple years ago, largely in response to the opioid crisis, put together a task force that came out with a couple of deliverables. One of them was an action plan for pain in Canada, outlining 6 goals on how to move the epidemic of pain, chronic pain forward. And goal number 6 is there is improved and equitable access to services for populations disproportionately impacted by pain. Well, gender diverse folks are on there. Sexually diverse folks are on there as well. Today's presentation is focusing on gender diverse folks. And then we're working on some of this. So implementing pre and post licensure training for health professionals regarding sexual and gender diversity and pain specific condition considerations. Check, you're here today. Good on you. Thank you for being here. Encourage and normalize the use of gender inclusive pronouns in your teaching, in your research, in your service delivery with your patients. What does that mean? We'll talk a little bit more about that in a few minutes. Use gender and sexual identity affirming language in all of your communication to and with people living with pain and their families. This includes not just when we're communicating with folks, but also when we're writing, when we have our intake surveys, when we're doing research, when we're even talking with health professionals. That's what your language should just generally be. So, what are we doing? Okay, so let's talk about a gender affirming model of care. So in case I haven't already made this point, I'm going to make it again and beat this drum of mine. Gender variations are not necessarily disorders. Really, it's what makes it a disorder is the world around us not accepting. And gender variation has been around since the beginning of time. Gender presentations are diverse, they're varied across culture, and it's also important to think about culturally sensitive care when providing care. Gender involves an interweaving over time with biology, development, socialization, culture, and context. The other thing that I think is a hard concept for folks to sometimes wrap their minds around is gender may be fluid. It is not always binary. And it might be fluid for a person over the course of their life. The way they express their gender might change. And there isn't necessarily pathology in that. And this is the piece that I want to drive home is gender pathology lies more in the culture than it does in the person. So the more that we say that something is wrong, the more likely that person is to feel like something is terribly wrong with them, the more likely they are to have anxiety, depression, discrimination, trauma resulting from it. And so, being able to take a page out of those who came before us on this land, Two-Spirit has been part of Indigenous cultures here locally since the beginning of time, and being able to create space for different gendered expressions and learning about them is part of the education that we need to continue doing here. Okay, so what are we actually doing? We're checking our assumptions. I started off by telling you a little bit about myself, about my worldview, about the way I look at the world. And some of that also includes power and privilege. So, the more those folks who exist in with racialized backgrounds, minoritized backgrounds, tend to hold less power and less privilege. And with power and privilege, you often get a bigger platform, oftentimes for your voice. I encourage you to use your voices. All of you are here tonight because you're somehow associated with providing care in a medical context. That means there is some power and privilege afforded with that. What are you doing with it to be able to advocate for those who have a hard time having their voice heard? Language matters. Always, always, always be using inclusive language. Sometimes, I think sometimes that's a hard thing for somebody to do, especially if there's a switch in, say, pronouns for a patient. You've known them before. Continue just pushing yourself and moving forward and trying to use the appropriate pronouns that that patient has asked you to use. And sometimes when you don't know, you can use gender neutral language, partner, spouse. Even thinking about using it in your own life, referring to brothers and sisters as siblings, or, instead of a niece or nephew, use the word nibbling. Um, if a patient uses a term or word that you're unfamiliar with in the moment, ask for clarification because it might impact patient care. You want to be able to be communicating clearly with your patient, but after the appointment, get on the internet, do some research, learn about it yourself, and don't put the burden on the patient to do all of the educating. So you might need clarification in that moment of what are you referring to when you use that word? And then move along after you get the definition and then do your own homework afterwards. Signal that you and your clinic are a safe space. Introduce yourself with your pronouns. So, and I give an example on here. This is what I say to all of my patients. Hi, I'm Dr. Effie Mujanis. I'm a registered clinical psychologist. You can call me Dr. Effie or Effie. I use both she, her, and they, them pronouns. What would you like for me to call you? What are your pronouns? Do this for all your patients. You then, you just get into this knee-jerk habit of that's the way that you're engaging in the world. And sometimes I get feedback of like, oh gosh, what if I offend somebody? Oh gosh, what if they ask me why? And to that, I reply having a simple statement that you say, and I give an example of it here. It's important that all my patients feel safe and seen, and we know that gender diverse patients face more discrimination in healthcare settings. We don't want to make assumptions here. So it's just part of our practice to ask everyone how they want to be referred to. And that's your response, and you move forward with your care. And what this does for patients who, this is like the quickest, fastest signaling of like, I'm here. I see you. I hear you. I want this to be a safe space. There's other things too. You can put your pronouns on your name badges, on your emails, have signage up that indicates safety, flags, etc. I know that sometimes buildings were created a long time ago and tend to be gendered, but as we move forward, the more we can make our washrooms single stall washrooms and just call them washrooms without gender or sex markers is fantastic. I didn't go into all of this data, but a lot of violence that exists towards transgender people occur in bathrooms. And I want you to think about that for a minute. Voiding your bladder and your bowels is one of the more basic human behaviors that we engage in. Most of us don't really think about it day to day. We go to the bathroom, we do our thing, we come back. But imagine that every time you did that, you were anxious because you didn't know if somebody was going to misgender you or tell you where you were in the wrong place or beat you up for being there. And so this is the biggest one that if we could make a sweeping fix in terms of safety, like a lot could be better if washrooms were single stall washrooms. Look at your forms in your clinic. Make sure they use inclusive language. Get rid of the gender binary on there and make sure that there are inclusive options to mark for both gender and for sexuality. So I really like this. This comes from a big name more in the pediatric gender community, but this idea of gender health is an opportunity to live in gender that feels most real and or comfortable, to express your gender and freedom from restriction and rejection, and I would add, and to feel safe, and ability to be supported in your gender. So, gender affirming model goals, treatment goals, is like facilitating an authentic gendered self, figuring out ways how to support your patients to alleviate the gender stress or distress, building resilience and securing social supports. So, one of the things we see a lot of risk factors associated with social determinants of health, housing insecurity, food insecurity, lack of support. There are tons and tons of papers that talk about research papers that talk about how the rejection from family really sets patients on really poor trajectories for health outcomes, social outcomes, educational outcomes. So when you're finding, a young person in front of you who is lacking social support, that is kind of one of the first things that we can do. How can we put them into a place that feels safer and building resilience? So thank you to, the social workers who are here tonight who help us with those jobs. That is so critically imperative for these young folks coming in. The other thing that I will let you all know is that it's not always about gender. So for that transgender person who comes into your clinic and the primary concern is about chronic pain, well, it's about chronic pain. So don't assume it's about their gender. So there's a funny term called trans broken arm syndrome. I think it's a funny term, at least. But really, it's when we medically misattribute and have invasive and inappropriate questioning. And there's a recent study that came out, and basically it came out with a couple different themes that assumptions of disordered thinking and being and hyperfocus. We tend to hyperfocus on aspects of gender affirming medical procedures as opposed to the primary presenting concern. There's cultural ignorance and general incompetence around gender diverse populations, and then general dismissiveness of the patient. These are the ways trans broken arm syndrome can present itself. So, what are some strategies for assessing a gender diverse patient with chronic pain? What are they coming in for? What is the presenting concern? Let that ground your work, the diagnostic portion of it, the questions you ask, the exam that you do, especially to avoid trans broken arm syndrome. You should be screening for risk factors and social determinants of health. And here I have some that are really important, that these are the overlap areas that I was talking about with both risk factors for chronic pain and things that we see in off the chart numbers in the gender diverse population. So depression, and if you are using Epic, My Chart, nope, what's it called? Connect Care. Some of these features are already built in, the PHQ-2, the PHQ-9, GAD-7, and then simple screening questions about safety, social support, food insecurity, housing security, screen for substances, ask about sleep. These are important pieces. Obviously, if they're coming in for chronic pain, you're going to move your assessment towards chronic pain. If they're coming in for a well check visit, or to establish new care, it's really important that you get a full breadth and depth and picture of them. Where are they living? Who are they living with? Who takes care of them? Who supports these people? Where, and those are really important pieces to like think about, and more even so in like a prevention model too, to make sure that are we looking at other things that can contribute to chronic pain down the line. So when assessing, this is kind of a continuation for the last side, assessing for pain, we want to know the basics. We want to know onset. We want to know location. We want to know duration. We want to know frequency and intensity. Always, 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 in this medical world, we want to explore for biological etiology. And just a reminder, I know that all folks here aren't working just in a chronic pain context. You guys are mostly from, primary care. But just a reminder, all pain is real, whether it has a biological etiology or not, it is real. And I can't tell you, I'd say over 85% of the patients that I see, I'm shooting from the hip here on that number, come in and tell me how they feel invalidated and misbelieved by oftentimes other doctors and medical providers that their pain, isn't real or can be swept away or subsumed under this gender dysphoria umbrella or this anxiety or depression umbrella. I think the anxiety one often tends to impact folks who identify as female. They'll often present after years and years of chronic pain and say, well, I think I was just told that it was my anxiety. But please don't do that. Always rule out biological etiology, and above and beyond everything else, I encourage you to, to believe your patients. I know that feels like a silly thing, but that's the stance that I kind of work from. That what they're telling me is a truth in their eyes, and if you can get behind that and put yourself in their place and kind of take on their worldview and their perspective, it helps you be a better provider. There's some other pieces I want to also share in terms of life course considerations. So, two-thirds of youth with chronic pain, they become the adults with chronic pain. So when they present to you in adulthood with chronic pain, more times than not, it didn't start then. Chronic pain tends to run in families. We are seeing this more and more, and this is something that you can ask about in your assessment. Gender identity and gender exploration can present at any age. So I didn't talk about it much today in terms of youth and gender identity, but it doesn't necessarily have to come out in youth. There are many folks who who explore gender and go through gender affirming changes later on in their lives. Adolescence is of a particularly relevant time period for all of these things that I was talking about this evening with regard to pain, with regard to mental health and identity formation, and can be particularly tumultuous. There's so much growth that's happening, both from a biological standpoint and, in terms of the social aspects of life around you as well. You're gaining more autonomy and, the hormones and so many things that are changing in your body during that period of time. I'm going to do, I don't know, one of the breakdowns we didn't look at is I don't know how many of you work with kiddos. So that's actually how I get launched into psychology is pediatric psychology. So I'm going to do a couple of slides on youth here. So there are unique psychosocial concerns for youth, namely a lot having to do with even more so with the restrooms. And the rejection piece that I've already talked about, that is a big piece. Rejection, discrimination, bullying, and we often see risky behavior, and that risky behavior doesn't necessarily it can be a inappropriate way of coping with pain. We see increased substance use both in youth and adults who identify as transgender and gender diverse and sexual minorities as well. But these are pieces that are important to think about. Survival sex, for those of you who don't know what that means, young folks who have been kicked out of their families of origin may engage in something called survival sex, which means essentially they're having sex to put a roof over their heads at night. And as you can imagine, it's incredibly dangerous, and you can see why trauma is so highly prevalent that, with the discrimination and the rejection. So some other important pieces to assess for safety and risk specifically in youth is kind of understanding the home life a little bit. Are folks supportive of your gender identity? Understanding a little bit about safety of education and employment. We often want to make sure that we want to check in, especially with youth and young adults, about eating behaviors, as we often see disordered eating as a means to sort of impact their bodies and change them in a way that feel more congruent to gendered self. but they often do it in ways that are harmful. So it's important to ask about it. Again, substances, ask about gender, ask about sexuality, assess for suicide and depression and safety. One of the important things as healthcare providers, you will often be a place of safety for many of these young folks, especially if you're seeing adolescents and they're practicing learning how to be a independent human in the world. They might come to an appointment on their own, even if their parent drove them. The parent might sit in the waiting room, which is, appropriate for teaching them how to engage in the healthcare system. If an adolescent discloses their gender identity to you, it's important in terms of safety to understand who else they've disclosed their identity to. And I know that the law is currently, there's some legislature changes that have been transphobic. I'm going to say it how it is. That tie our hands in terms of how we can best support the youth currently. But, first and foremost, assessing for safety is going to be really, really important. So you don't want to inadvertently, if they've identified you as a safe person, and they're not out to their parents, you don't want to inadvertently out them, because that could put them at risk. That's why some of the changes with having identifying parents, asking parents before they change, use of names or pronouns at school is particularly concerning in the current legislature. Anyhow, safety, assess for safety. Recommended approaches to care. So, some other pieces to think about. Provide both virtual and in-person options if you are able to. There's a study that came out that talked about gender diverse folk who had a chronic health condition preferred more virtual, but those who had a less supportive environment at home preferred to come in person. So if you can diversify your options in your practice, that's helpful for them. When you're gathering sensitive information, make sure that's needed for whatever they're presenting for. And I would say every time you're doing something, explain to the patient why you are asking for the information, why you are doing the exam that you're doing, why you're requesting, giving them the requisition to do the thing that they're doing. Use gender neutral language whenever possible. So I have an example here. If it's medically necessary to assess a transgender male's chest, and they have breasts, you might refer to the area as the chest or the front side of your torso, as opposed to calling it your breasts, which can be gender dysphoric for them. Don't assume what organs are present if somebody is presenting you to the first time to establish care. Or organ inventory is just figuring out what exists to guide your preventative and screening approaches are going to be the best case scenario, and explain this. So, I'm going to ask a little bit about what organs you currently have. So if you're talking to somebody who's assigned female at birth, but is a transgender male in front of you, and you're establishing new care for the first time, this would be something that you might want to do at a first appointment to establish how often you want to do types of screening. So they might have had a radical hysterectomy, have removed their cervix, and so you might not need to do an annual PAP or however after 5 years, I think is anyhow. Explain to your patient why you're doing what you're doing. This will always help you avoid trans broken arm syndrome and making them feel like, oh gosh, like I'm a pincushion and they're trying to like experiment on me, or they're just trying to ask things that are none of their business, or feeling dismissed or invalidated or discriminated against. Um, that sort of brings it to the end to, I had a study to talk about a case study on here, but I'm actually going to skip over it and present you some of the resources I have for the sake of time to allow for enough time for questions. So gender affirming care resources for primary care providers. So there is a wonderful, wonderful, wonderful document that was put out by Primary Care Alberta that was literally just updated less than 6 months ago with a great interdisciplinary committee on a pathway to provide gender affirming care. And it goes step by step in terms of if you're going to, help a patient start with hormone affirming treatments. It talks a little bit about that. It provides resources. It's a fantastic document. And here's some other places to look for care. This is for primary care providers in general. I would say not just physicians, but I would assume most allied health providers would probably get a good bit from a lot of these resources here. And so we will find a way to get these out to you. Chronic pain resources. Here's a couple of really good ones. Power Over Pain. Pain U is a great self module that you go through on your own that has great pain science education and tools on it. I also put a link here for the Health Canada's action plan for pain in Canada. Health Canada chronic pain resources I've also included. They have a great page of resources, and the Calgary Chronic Pain Center, which is us. We're still working on the web page, but we have a great multitude of resources, including 5 fantastic videos about chronic pain. So if you have a patient that you're managing that says that like you've referred to us, but we have a wait list. We're working on that. And you want them to learn more about chronic pain, get them on the website, have them look at some of these videos. They're remarkably helpful in terms of giving them knowledge and a launching point to begin a bit more of like self-management. I've also included some resources for patients and families. This first one, the resource list is actually from the AHS website. It's a great list. In fact, there's probably like 20 local resources on there for not just gender diverse and transgender folks, but the entire LGBTQ plus Two-Spirit community population. And so Outlink is a good one. Skipping Stone is a fantastic organization, local organization. That's great. And the Center for Sexuality as well is a great resource. And then I got lots of references. That is the end of my song and dance this evening. I'm going to stop sharing. Maybe I'll see some faces. And I don't, there's maybe a moderator for questions, or am I moderating for questions? I'm not sure. I can't remember.
I think Jan was going to be moderating questions.
Yeah, no, that's why I was asking Nicole, like, if she's now going to replace me or not, because I wasn't quite sure if I managed it in time to get in here. Okay, well, questions. Do we have any questions? I need to actually check them. Why I don't have any Q&A on my screen here?
One question here about resources for gender diverse people in Edmonton who have chronic pain. To be honest, I'm less familiar with Edmonton, Shannon. I don't know. The great thing about a lot of the resources and services on here, I mean, many of them are web-based and self-directed. Many of them can be applied virtually. So I would start there. If there's anything else that folks know of, feel free to pop it in the chat. Sort of, populate it for yourselves. Alas, I don't know any off the top of my head. I'm sorry.
And the other question was, I'm wondering if you could suggest terms for an intake form to avoid othering, alternative to the options being male, female, other.
So just questions on what else to include.
Well, that would be my guess.
Okay. That's a great question. I think that people do it different ways. So if you're trying to collect data, you probably want a box to check off. If you don't want to collect data, you can have them fill it in themselves. But at the very least, I would say male, female, transgender, non-binary, and you can put an other box as well. For gender, for sexuality, gosh, I feel like there's a lot of debate on what to put on there. I think that queer tends to be the umbrella term to trans. I mean, you could put queer, so straight, lesbian, gay. Um, gosh, I think that I'd have to look to see what it, there's some people are putting some links in there. I don't know if it's for that, but that question is a little harder for me to think off the top of my head. I'd have to look at resources first to see how, and I know that sometimes the way things are captured, I'm coming to you as an American are slightly different in the States versus here. Not that there's, whopping differences in sexuality as you cross the border. But, I'd have to get back to you on that one.
Okay, sounds good. And the last one, at least, like on my screen, is that it was amazing. Do you have any information on supportive gender diverse older adults with or without pain, particularly those in care?
Gender diverse adults with pain, that was the question.
Diverse adult, older adults with or without pain, but particularly
Um,
those in care.
yeah. I think I don't have resources specifically. One of the things that I will add is in the Canada, the Trans Pulse study. They did pull out older adults and they did a special report there. I didn't include it today because it was either I could either pick um, the special report on folks with disabilities or older adults. So I went with disabilities because it captured more chronic pain, so less overlap. So I don't have any specific resource to point you to off the top of my head. And I did tend to talk a little bit more about youth just because that's what we're seeing presenting in clinics is usually more around that like young adult age, the gender diverse folks with chronic pain. That doesn't mean to, of course, say there's obviously gender diverse older adults out there as well. But I don't have resources off the top of my head for that. I'm sorry.
I guess we are going to forgive you. Okay. And that would be it. Okay, let me see if we have anything in our chat.
Yep, happy to share my references.
Yeah, so like there is a feedback, skipping stone or outlink are both good for the older adults as well. Okay, so then I guess like that would be it for this evening. So thank you very much, Dr. Effie, for your presentation. It was very informative. And this is something that I guess like we all need to learn a little bit more to change the culture and make everybody feeling welcome and safe in our clinics. So yeah, so thank you very much for everything that we have learned from you today. And well, maybe we will see you again someday in the future.
Folks, I appreciate it. Thank you for listening. Thank you for coming.